Hi everyone, Dr. Mike here. In this video, we're taking a look at respiratory acidosis and alkalosis. Let's take a look. All right, to begin, let's talk about those delicious carbohydrates and fats. You know, those delicious macronutrients that we ingest every single day. Carbs and fats, and I'm ignoring proteins for the time being, the third macronutrient, because I'm going to focus on it in metabolic acidosis, alkalosis. Carbs and fats, we know, are made up of carbons, hydrogens, and oxygens, right? And I've said to you previously that one of the major things or purposes of metabolism is to steal the hydrogens away to hand off to the electron transport chain in the mitochondria, so that it can participate in oxidative phosphorylation. That makes huge amounts of ATP. Now, that's great because we need energy in all the tissues of our body, but what are we left with? What are the remnants of the carbs and fats after we do this? It's carbons and oxygens, which you could snap together to form carbon dioxide. So carbon dioxide is the byproduct of metabolism. That's important, and we don't want it. It's the exhaust fumes of metabolic processes. Now, all the tissues of your body that need energy will undergo this process, right? So it's important because all these tissues are making carbon dioxide. Even the tips of my toes are making carbon dioxide. It needs to get rid of it. How? It needs to send it to my lungs. And it does this via the bloodstream. So this carbon dioxide must enter the bloodstream. So I've got carbon dioxide here. And when it enters the bloodstream, it mixes with water in the blood because the blood is mostly water. What this produces, if you just add all these components together, is H2CO3, which is carbonic acid. And we've spoken about acids. The definition of an acid, or at least mine, is that they hate themselves and they split themselves apart and they ultimately produce hydrogen ions, but in this case, also bicarbonate ions. So what this is telling us is that the carbon dioxide produced in our tissues from the metabolism of carbs and fats actually get transported in our bloodstream mostly as bicarbonate ions. Brilliant. Then when it gets to the lungs, it binds back with hydrogen ions to form carbonic acid, which forms carbon dioxide again, and we can breathe it out. This is extremely important because we produce huge amounts of carbon dioxide every single day. The amount of carbon dioxide we produce from this metabolic process is 15,000 millimoles of carbon dioxide every single day. Now, you go, yeah, okay, 15,000, that's a big number. What does that mean? That's about 336 liters of carbon dioxide we produce as a byproduct of metabolism every day. That's basically 24 party balloons filled with carbon dioxide. So we have to get rid of it. And one of the reasons why we have to get rid of it is carbon dioxide produces hydrogen ions. And as you know from previous videos, when carbon dioxide levels go up, so will hydrogen ion levels go up. So if we accumulate carbon dioxide, we can become acidic. Okay, what about vice versa? If I were to get rid of my carbon dioxide and it drops down, well, the hydrogen ion levels will also drop and we can become alkalinic. This is important also because carbon dioxide, as we said, is managed by the lungs. That's how we get rid of it. Therefore, if you have an increase in carbon dioxide, that concurrent increase that you get, or the subsequent increase in hydrogen ions, is what we call respiratory acidosis. That's it. Respiratory acidosis is simply when the carbon dioxide levels go too high. When the carbon dioxide levels go too low because the thinking is, well, the respiratory system has got rid of too much, this is what we call respiratory alkalosis. So as you can see, when it comes to respiratory acidosis and alkalosis, it's pretty easy in the sense that it's just the levels of carbon dioxide. Now we need to talk about what can cause it. What causes us to accumulate too much carbon dioxide? Effectively, it's anything that stops us from getting rid of it from our lungs. So we need to talk about all the anatomy and physiology that allows for us to breathe out. So there's a couple of components here. One is the lungs. So here I've got a very simplistic example of the airways and one giant lung here with the pleural cavity here, right? So the first thing we need to understand is lungs. They're important. Second thing is the chest wall. Bones, such as the ribs, and the muscles, like the external intercostals, internal intercostals, and the diaphragm. So you could say the second thing that's important to understand is the musculoskeletal component. Third are the neurons. These muscles won't contract to allow the lungs to expand and deflate without neurons. And so we need peripheral neurons and central neurons. So importantly, we've got the brain stem, and the spinal cord. We've got the midbrain, the pons, and the medulla. You can see here in the medulla, this area I've highlighted, this is the respiratory zone in the medulla oblongata. This respiratory zone will send signals down via motor neurons. So you're going to have an upper motor neuron here that will synapse, and this motor neuron, this lower motor neuron, innervates the diaphragm to contract. So that's the phrenic nerve. This upper motor neuron will synapse with thoracic nerves that will come out and innervate the intercostal muscles. All right, so we've got central neurons and peripheral neurons. So that means the other thing that we need to understand is the nervous system that contributes to being able to breathe out. So this is how I break it up. Lungs, musculoskeletal, nervous. Anything that can affect any of these that reduce the amount of carbon dioxide we can exhale and therefore we accumulate carbon dioxide, that can cause a respiratory acidosis. So let's start with the lungs, right? So what could stop carbon dioxide being released? Well, anything that obstructs or blocks the movement of gases out of the lungs, movement of gases out of the tubes. So probably one of the most important ones here is something we call COPD, which is chronic obstructive pulmonary disease. This is made up of, this is an umbrella term for two conditions, right? One is called emphysema, and the other is called chronic bronchitis. There's a lot of overlap with these two conditions, but effectively the way you should think about this is, if I were to look in here and have a look at an alveoli, or an alveolus, I should say, is singular. So there's the alveolus, and here's the blood going past. What you probably already know is that the carbon dioxide that's coming past, that needs to diffuse across the respiratory membrane, and that carbon dioxide needs to be breathed out and ultimately will exit. At the same time, we've got oxygen coming in, and this oxygen needs to diffuse across the respiratory membrane, and that oxygen needs to go to the tissues of the body. So an important thing to understand is that all your alveoli are attached to elastic tissue. This elastic tissue is attached to the surrounding area. This elastic tissue keeps our airways open, right? Think about having elastic tissue attached to the ends of a balloon. It keeps it open. And then when you want to take a breath in, you stretch that elastic, as in like you pull on it, right? You pull on it and the airways open up and you take a breath in. And then when you want to take a breath out, you just relax and you get the elastic recoil, and then the air can come back out again. So that's important, the elastic tissue for normal breathing. But in emphysema, the cigarette smoke destroys this elastic tissue. So what that means is the airways aren't kept nice and tightly open, right? Now, when you take a breath in emphysema, you can still open it up and stretch it, right? Think about it as a really dodgy, crappy rubber band, elastic band, right? When you've got a really good one, or let's say you've got 5 rubber bands together, right? They're really hard to stretch, but they snap back really well. That's how it normally is. But when you've got one really crappy one, so that's been degraded over time, like in emphysema, it's super stretchy, but it doesn't snap back very well. That's what happens here. So it can open up, but then when you go to take a breath out, they collapse. They collapse because the elastic bands aren't there to keep it open. So in emphysema, airways collapse, stopping carbon dioxide from being blown out, and it traps, carbon dioxide traps in the lungs. And so this is why people with emphysema can get hyperinflation. They get what's called a barrel chest. So in emphysema, CO2 accumulates because it's hard to get rid of it. In chronic bronchitis, which there's a lot of overlap between the two, if you have emphysema, you've probably got some degree of chronic bronchitis and vice versa. Emphysema, there's a mucus buildup. And so this mucus buildup that occurs is going to narrow those airways. And if it narrows the airways, well, it's going to be really hard to get that carbon dioxide out. So again, respiratory acidosis can occur. You can also have asthma. Asthma is another obstructive condition. But in asthma, the airways narrow because the muscle that surrounds it constricts. They're hyper-responsive and it narrows that. Or you can have a foreign object inhaled, which is blocking one of the bigger pipes. So you can have aspiration of object, and that blocks the carbon dioxide from being released, causing a respiratory acidosis. Or you can have something, right, like a restrictive disorders. So you can have things like pulmonary edema. You can have pneumonia. You can have respiratory distress syndrome. Now, there's a lot of overlap with these three conditions, right? A lot of overlap, but effectively they all cause inflammation, right? So pulmonary edema can be a result of inflammation. Pneumonia can cause inflammation. Respiratory distress syndrome and inflammation can occur. And when inflammation occurs, fluid builds up. And when the fluid builds up, it makes the respiratory membrane thicker. So look at this. There's more area for the gases to have to diffuse across, making it more difficult, meaning more carbon or less carbon dioxide can travel across and more stays within the bloodstream. So all three of these conditions can cause respiratory acidosis. You can also have what's called pulmonary fibrosis. And in pulmonary fibrosis, so this can happen when you inhale things like asbestos and other matter that can cause inflammation. It can cause the connective tissue to scar, again, causing thickening of the respiratory membrane, making it harder for the gases to move across. This thing here, which is called the pleural cavity, right? There's two membranes or two layers to it. You've got the visceral pleura, the one that's attached to the lung tissue, and then you've got the parietal pleura, the one that's attached to the thoracic wall. In between is the pleural cavity. That's negative in pressure and has a bit of fluid called pleural fluid that is produced, right? So this is important because it's negative. Both of those membranes adhere to each other. And that's important because when these external intercostal muscles contract and lift the rib cage up and out, it pulls on this membrane of the pleural cavity, the parietal pleura, but that pulls on the visceral pleura, which pulls on the lungs. So that's how the lungs stretch or move with the rib cage. Therefore, if you damage the pleura and put a hole in it, air will rush in because it's negative inside, and there's no more sticking of those membranes and the lung collapses. That can lead to carbon dioxide not leaving. So this could be called, depending on what's happening, if it's just air that's entering, that's a pneumothorax. Or if it's blood that's entering, that's a hemothorax. Right? Or if it's fluid, it's a pleural effusion. But effectively the same thing is happening. The lung is not inflating, deflating properly, carbon dioxide trapping. Okay, so these are the lung causes of respiratory acidosis. What about the musculoskeletal causes? Well, what if you had broken ribs? If your ribs were busted, right? Broken ribs. Have you ever had a busted rib? Have you even had a bruised rib or bruised cartilage? It hurts every time you breathe. If you've got a couple of busted ribs, you can have chest flail, which makes the ribs move in an opposite direction to the way you want them to, and that can result in carbon dioxide trapping and not leaving the body. You can also have your spine, for example, right? So if you could have kyphosis or you could have scoliosis. So kyphosis is like an S bend of the spine. Scoliosis is an anterior-posterior bend of the spine, like sort of, an exaggerated version of hunched over. That alters the way the rib cage can expand in and out, and obviously alter the way that gas moves in and out. So you can have these particular conditions, right? Oh, you could also have muscular dystrophy. So this is going to be the muscles aren't working properly, so the muscles can't contract, can't expand the rib cage appropriately. So you can have MSK disorders. What about nervous system disorders? What can happen here? So you could have, let's first focus, let's go from here and then move more centrally. So if we look at the muscle itself, and that's stopping the neuron from getting to it, or the neurotransmitter that the neuron releases. Remember, the lower motor neuron releases acetylcholine, and that needs to bind to acetylcholine receptors on the end plate of the muscle. Once the acetylcholine binds, that muscle can contract, right? But if you've got something that blocks the binding of this acetylcholine at the muscle, well, then you don't get that muscle contracting. And so that could be myasthenia gravis. Myasthenia gravis, autoantibodies or antibodies come in that bind to the acetylcholine receptors, stopping acetylcholine from binding. So you can have myasthenia gravis. Specifically, it would be a myasthenic crisis, so an exacerbation of myasthenia gravis would cause this. So that's the acetylcholine binding to it. What about the acetylcholine being released, right? So if something stops the acetylcholine from being released from the lower motor neuron, that could be botulism, right? Botulism does this. Botulism stops the acetylcholine from being released, and therefore you also get paralysis of the muscle. Okay, what else can happen? You can have just destruction of the motor neuron itself, and that could be like ALS, so amyotrophic lateral sclerosis can destroy it. Poliomyelitis, so poliomyelitis as well. Poliomyelitis, that can destroy the motor neurons. And again, if they're destroyed, then you don't get contraction of the muscles. What if you had a problem in the spinal cord and you had a toxin that was inhibiting all the inhibitory neurotransmitters? So think about this. You want a muscle to contract? Excitatory signal, contract. But if you need things in here that inhibit motor neurons, otherwise it just constantly contracts. So you need interneurons, right, that release things like GABA, which is an inhibitory neurotransmitter. Well, you can have something called tetanus, and tetanus can block this GABA. And if you have that GABA blocked, then you've got overcontraction, and all the muscles just contract too hard. And if they're all contracted, they can't relax. So they stay contracted. And so tetanus or tetany means just everything's contracted at once. You can also get Guillain-Barré syndrome. So Guillain-Barré, or if you're here in Australia, Guillain-Barré. So Guillain-Barré is probably how you should be pronouncing it. That is a demyelinating, so let's say demyelinating of the peripheral neurons, right? And that's Guillain-Barré syndrome. Similar to Guillain-Barré syndrome, which is demyelinating of the peripheral, we can have demyelinating of the central nervous system, right? And this demyelination of the central nervous system is MS, multiple sclerosis. Demyelinating, that can be multiple sclerosis. You can also have, I know there's a bunch, you can also have brain injury, right? So anything that damages this area here, right? So it could be trauma or tumor. They can result in depressing if you depress the respiratory center of the medulla, you don't breathe out as much carbon dioxide. That makes total sense. Or you can have drugs. Drugs can depress this, right? So like opioids, like morphine, right? Opioids could do it, barbiturates. I'll just write barbs, barbiturates. They could do it as well, all right? Now, one final thing, the last thing that you should probably know that can lead to respiratory acidosis is when somebody's on a ventilator, if the mechanical ventilator is underventilating, it means that that person who is using the ventilator, right, they're obviously induced, right? So they're generally not conscious. They can accumulate carbon dioxide. So I would say that the fourth and final one, right, would be mechanical ventilation. And in mechanical ventilation, it's under ventilation, accumulating that carbon dioxide. All right. So that's the causes of respiratory acidosis. Let's now take a look at the causes of respiratory alkalosis. So it's easier in a sense because this is when we get rid of too much carbon dioxide. So effectively anything that results in hyperventilation. So we've just done acidosis. With alkalosis, effectively, it's anything that causes hyperventilation, right? By far, the biggest cause here is going to be anxiety. Anxiety is the biggest cause of both acute and chronic respiratory alkalosis. Anything else that can cause hyperventilation could be things like pain. When you're in pain, it can cause you to hyperventilate. So can fever as well, right? Now, in addition to that, anything that decreases O2 levels can cause alkalosis. Why? Because alkalosis is a drop in CO2. So why this? Because if O2 drops, it stimulates the respiratory center for you to breathe faster. And if you breathe faster, you can blow off too much carbon dioxide. So examples of drops in O2 could be high altitude, right? High altitude climbing or whatever it might be, but high altitude where the O2 is low. Fever can also be one here because when you have a fever, metabolism goes up and your demand for oxygen goes up. So that could also be the case. But things like anemia, right? Severe anemia, where your red blood cells are low, therefore your oxygen carrying capacity is low, that could cause it. And even some of these things, right? So mild forms of like pulmonary edema or even a pulmonary embolism can cause a stimulation of that because it's saying, oh, hey, there's a problem with this respiratory membrane. Yes, I'm not getting rid of enough carbon dioxide, but I'm not getting enough oxygen in. So oxygen levels drop and therefore it stimulates the respiratory zone and you can start to hyperventilate in mild or early stages of this and get a respiratory alkalosis. Then when this is so bad that the carbon dioxide can't diffuse, then it can be turn into a respiratory acidosis. And then finally, anything that actually directly stimulates or increases the respiratory center in the medulla, right? So anything that actually stimulates this, which could be trauma, tumor, and drugs, right? So it just depends on the type of trauma and tumor. Trauma, tumor, and when it comes to drugs, some drugs like salicylates, like salicylic acid, so that's like aspirin, right? High doses in the early stages can stimulate respiration, but in the latter stages, it can actually be a problem, can cause acidosis. But in the early stages, alkalosis. So this is a run through of what respiratory acidosis and alkalosis is and the various causes. I'm Dr. Mike and I hope that helps. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.